All right. Hi, I'm Dr. Brian Karopian, and I'm here to talk to you about my favorite dental subject, sleep disorder dentistry, sleep apnea, snoring, CPAP intolerance, and how we as dentists can treat this and treat it successfully. I'm going to talk to you about the full breath solution, the new and unique one-arched dental appliance that will control the tongue like the CPAP does. All right, give you a little background about myself. I practice in Tarzana, California. You know, the sleepy little hollow outside of L.A. where Tarzan wrote, where Edgar Rice Burroughs wrote Tarzan. Went to the University of Southern California, graduated. I've been doing TMJ for 29 years. And I've been on the American Board of Directors for the American Academy of Craniofacial Pain for 17. I've been the treasurer, and I've been the president of the Alliance of TMD organizations. And the Alliance is where all the groups that treat TMJ get together and try to mash out all the ground rules and just how we do it. And I've been past chairman of the peer review committee for the San Fernando Valley Dental Society. My dental sleep background, I started treating sleep in 2002. I joined the American Academy of Dental Sleep Medicine in 2003. I got my first dental patent on this appliance in 2004. I got a second one in 2008. And then I've got 4 FDA approvals associated with this. So we've got a lot of good scientific validity for what we've got here, and I want to show you why this is going to go. All right, dental sleep disorders. 90 million Americans snore. That's your market, 90 million Americans. And there's some others. The markets also include some others, but this is the big thing. Because of that 90 million, about 80 million have sleep apnea. 60% of all Americans over 40 snore. 27% of all American couples over 40 sleep in separate bedrooms due to snoring. Wow, that's a big one. And the CPAP industry, and the CPAP is the mask that fits over the face that blows air up the nose, pushes the tongue out of the way with that air pressure, and the tongue is falling back, blocking the airway. CPAP is the #1 medical treatment for this, and it grosses $4 billion a year. But of all those people who get treated, 75% reject it. 75%. Wow. That 75% are all patients that are candidates for oral appliances. 75% rejecting the CPAP. And here's the CPAP. It fits over the nose, blows air up the nose, comes down, and pushes this tongue forward, opens airway. When it can be tolerated, 100% successful. We're very fortunate in dentistry. The medical profession has paved the way for us in treating this. What do you mean pave the way? It's paved the way with the insurance companies. The insurance companies pay for CPAP. And why do they pay for CPAP? They know how important air is for when we sleep. And they realize the gravity of this situation, and so they pay for oral appliances. Medicare pays for oral appliances in sleep dentistry. Now, it's different in every state. In California, where I'm from, it pays very, very well. But thanks to our medical brothers, hey, we got something new in dentistry that we can work with the insurance companies and Medicare. And because of this, and because of 2 facts. One, the CPAP is rejected 75% of the time. Oral appliances are effective. And we've got insurance and Medicare that pay for this. This arena has been handed to us on a silver platter. Wow. Now, how are we going to take advantage of, 1, getting the public better, 2, being able to be compensated for what we do. Well, first of all, the answer for dentistry for the next generation of a successful treatment of sleep disorders is the full breath solution dental appliance. And this is the appliance that I use. And here it is right here. Just like an upper bruxism appliance, it fits over the upper, one arched. All the other appliances are two arched. And the other appliances work by basically moving the mandible forward. Why move forward? Because the tongue that is fallen back, we're going to pull the tongue forward. Now, we don't do that with this appliance, and we're going to talk about how this appliance works. Okay, we've got the upper bruxism appliance with a little bar back here. It's called a transpalatal bar. And originally, before we had this piece right here, this little bar held the tongue down, restrained and inhibited the tongue from going up and back. Now, this bar, this anterior portion of the bar, our anterior tongue restrainer, prevents the front of the tongue from going up and back. It holds it. Now, right here, the back portion, right here, the posterior tongue restrainer prevents the back of the tongue from going up and back. And we're going to have to probably do a little expansion to help us out, but we are going to restrain and inhibit. And I will use that over and over again. We restrain and inhibit the tongue from going upwards and backwards and blocking the airway. And here we are again. This is our anterior tongue restrainer that prevents the front of the tongue from going up. Here's the posterior tongue restrainer. This prevents the tongue from going up and back. And here are indented occlusals so that if we move the jaw forward end to end, we don't come way out here. We may come end to end, 1 millimeter lingual. We've got a home plate that the jaw will go to over and over again. All right, here's a picture of many appliances. All right, this little one up here on the left is the NTI that many of you are familiar with. And all the NTI does is it opens your vertical. But if we could put a little portion on it that your back teeth have to come forward to, we can advance your mandible a little bit. So with the NTI, you can do very much the same thing you do with these big double-arched appliances. Open and advance the mandible, trying to drag the tongue forward. This appliance right here, and this is just kind of an overview of many, many appliances. The one on the middle in the right here is a tongue retaining device. And what this does is you stick your tongue in here, creates a suction, and holds your tongue forward. Looks comfortable, doesn't it? I tried a couple of them. I wasn't real enamored with this one. Now, this one right down here is called a tap. And this little device right down here is a little screw you turn, and as you turn it, the mandible advances. And you can just slowly start advancing the mandible by turning that screw. This one up here is a very unique one. These two little buttons, this is called the Oasis. These will keep the airway open, the nasal airway open, and it got the FDA approval for that. And it also, same way, it also advances the mandible. Now this one right here is called the EMA. This is upper and lowers, and with these straps, you make the little straps shorter here, and they force the mandible forward. And this here is the silencer, and it's just by putting little screws, you move it forward, attach the screw. Move it forward, attach the screw. All of them. What do they all do? Open the vertical, move the jaw forward. This blue one on the upper right is just one that some dentist made. A patient came in with it, and all it did is kept the patient locked forward. The one on the right in the middle is the Silent Night, a very, very popular appliance. FDA approved for snoring, but not for sleep apnea. And then on the bottom right is the full breath appliance that I just wanted you to see, one arch. Okay, how do these mouthpieces work? How a sleep appliance classically works is that it advances the mandible. And here we go, right right here on this upper left. Vertical is open, and we can see the lower anteriors are lingual of the maxillary anteriors. But here on the right, we're about 1 millimeter lingual. We have gone from here to here. We've advanced the mandible. We've also got things open. Here on the bottom right, bottom left, we've now got the end a little farther forward than end to end. And here on the bottom right, we've really got to pull forward. So classic appliances for sleep are open the vertical, and then move the mandible forward. The FBS, the full breath solution, works by controlling the cause of sleep apnea and snoring. What's the cause? The tongue going back. We're going to utilize the tail to prevent the tongue from going up and back. And we don't have to go advance the mandible 3 millimeters proggy. We're able to go 1 millimeter lingual to edge. Big change. We don't cause TMJ problems. We don't cause problems with the jaws being sore. We don't cause the bite to be off because the jaw's been forward. And here's our winning formula. Upper bruxism appliance, transpalatal bar, anterior tongue restrainer, posterior tongue restrainer. Now here it's a little bigger. It's been advanced. And as you can see, this tail is pointing towards the tongue. You got to flip this over because it fits on the top. And we aim it downward to start controlling the tongue. He who controls the tongue wins the sleep apnea game. Now, if you're going to just move forward 3 times and hope you get lucky, you ain't controlling the tongue. You don't have as much chance to win the sleep apnea game. But if you have something with a tail that can control the tongue, guess what? You can win that game. The CPAP is 100% successful because the air shoots up the nose, down the throat, behind the tongue, pushes it forward. It controls the tongue. The full breath with the transpalatal bar, the posterior tongue restrainer, we control the tongue. We both control the tongue. CPAP, full breath solution, guess what? We got success. This full breath is successful because it restrains and inhibits the tongue from moving upward and backward. And because we don't need to pull forward, guess what? No TMJ problems. Fantastic. So we can go here, and we don't have to worry about the jaws being sore. We don't have to worry about all of a sudden the bite feels off. Wow, we've got a sleep appliance that doesn't cause TMJ problems. Now, if you just want an appliance that you can adjust a couple of times, maybe move it forward 1 time, 2 times, 3 times, and that's it, full breath is not for you. But if you move it 1, 2, 3 times forward and they're still snoring, you got no other answers. You're a loser. And if you move it 3 times forward and you can't get that number of times they stop breathing to come down, and that's called the AHI. The AHI is the number of times the tongue rolls back and blocks the airway for 10 seconds up to 90 seconds. And if you can't stop that and lower that number, you're out of luck. You don't have a winner. The full breath solution is going to require some extra effort, but boy, it works. You are going to be able to treat snoring and sleep apnea successfully. How big do we make the tail, and why do we make it bigger? Well, the first thing is we add to this area right back here, and we will make this up to 1 inch. Well, how do we go about doing that? Well, here we have the little tail. We'll put some wax. Now, I like to use blue boxing wax. We can also use pink base plate wax, extended 1/4 inch. We now put it in the mouth. The patient says, not bad. Okay, well, let's now try, instead of adding a quarter inch to it, let's try adding a half. We add a half. Oh, no, I don't like that. Makes me gag. We cut that off. We leave it at a quarter. We now remove that wax, add clear acrylic, smooth it up, polish it, and now instead of having from the lab a little half-inch tail, we now have a 3/4 inch tail. Well, what's the advantage to that? Better control on controlling and restraining the tongue so it doesn't go up and back. Now, how big do we make it? The size of the tail is determined by two things. Obviously, comfort, because you can't get it. If they're not comfortable, you sure as heck can't make it all the way. And by the way, every once in a while, once a month, twice a month, with the transpalatal bar and the tail, you're going to get a patient that says, oh, no, that's bothering me. I can't take that. And what we do is we'll cut the tail in half, or we'll totally remove the tail. So all we have is that transpalatal bar with the bar in front, the anterior tongue restrainer. We'll leave them that way for 3 weeks, and then we'll add a little bit of a tail. Oh, not bad now. 3 weeks later, add a little more. 3-4 weeks later, add a little more. We can make longer tails by adding in small gradients. And it is shocking to me how much you can add to these tails that people can tolerate. Because there have been a couple that I've had to an inch, inch and a quarter. We may have even had one to an inch and a half. Unbelievable. But guess what? We stopped the snoring. We utilize, one is comfort we utilize to determine how much to make that tail. The other is a computer. It's called the pharyngometer. The pharyngometer comes from Harvard, and Harvard developed this so that we could measure the increase in airway that we can gain from the normal airway that could be somewhat restricted because of the tongue being back to an increased airway when we can restrain the tongue from going back and making it smaller. The pharyngometer has a little mouthpiece that fits right over this, what we call sensor bar. This fits into the mouth. It shoots out sonar waves, and this is called acoustic reflection. And these sonic waves act like radar, and they measure the airway from the back of the tongue to the epiglottis, right here. And they measure the size of that tunnel. And they will tell us how much air is going down that tunnel. Now, it'll also do it here in the nose. And this big, this long tube right here on the left will measure the nasal airway. And then we're able to show the differences that occur as we put in the full breath appliance. All right, here's our graph on the pharyngometer. All right, this green graph, the lower of the two graphs, is with nothing in the mouth. So we're measuring the airflow all the way down with nothing in one's mouth, and we see right up here under volume that based on the size of the pipe, the computer then will tell us how much oxygen will go down to the lungs. And we see here 22.05 cubic centimeters of air go down. Now, the next, right on top of that is the purple graph. And this is with the full breath solution that just came from the lab as it goes in the mouth. And we can see the graph is higher. Well, the graph is higher because it's reflecting more oxygen going down to the lungs. And we see here the volume as it measured it, we went from 22 cubic centimeters to 35. Bingo! We like that. Well, what do we like? We like the fact that this patient is getting 159% more oxygen into the lungs with the full breath than without. But here, next week, they come back a week later. We want to increase the airway because they tell us they're still snoring. We've got to make some changes. So we're now going to add some wax on the back of the full breath. And we do. And we've extended that tail from 1/2 inch to 3/4 inch. And look what happened. The volume went from 35 to 44. We increased the volume of air 127%. And you can see it here, right here on the graph. And here's the area, remember I talked about from the back of the tongue to the epiglottis, and here it is, this 10 to 20. That's what Harvard has told us to set off here, that represents the area we want to measure. And here's another one that shows that, wow, we went from 18 to 55. We increased this guy's airway 301%. Now, even though the guy is still snoring, when he sees figures like this, the patients are happy. Now, what happens if the patient comes in? Brand new patient. You run the pharyngometer, and maybe you do some work with, you open the bite a little bit with wax. You even put a piece of wax across the back, a little bar of wax from right first molar to left first molar, restrains the tongue. And you can show that you get a change like this 301%. Do you think you have a better chance, after you've explained everything to the patient, of convincing the patient to go into treatment, to accept your treatment, to willing to spend the dollars? You bet. So the pharyngometer is both a tremendous treatment tool and a tremendous sales tool. And I can't stress the importance of being able to educate the patient so they accept treatment. Because we know we've got great treatment, but boy, when you've got to tell a patient they got to come up with $2,000-$3,000 for treatment, you need some help. And Harvard's computer gives us a helping hand. The pharyngometer provides us with scientific data to treat sleep apnea successfully. The dentist can now adjust the sleep appliance to the position of maximum air intake. Wow. Dentistry has a tremendous, tremendous tool to help mankind get more air when they sleep and stop this horrible problem of lack of oxygen to every cell every night. Now, one of the discoveries I made while treating these patients is that those patients that had a high AHI, now again, the AHI is the number of times the tongue goes back, blocks the airway for 10 seconds up to 90 seconds per hour. And we will see patients that do this 5 to 20 times, which is mild sleep apnea, 20 to 39, which is moderate sleep apnea, and over 40 is severe. I get patients that do this 80 times an hour. Wow. What condition do you think they're in? Not good. And they can't wear a CPAP. Where's their answer? So patients that have a high AHI, above 15 and up, and patients that snore. So two things. Airways blocked for at least 15 times an hour, and they snore. Those patients have very little gag reflex. So, what does that mean? We can make a longer tail. They're not going to gag. And look at this. This illustrates it. Look at how far I'm able to put my tongue back on my finger back on the tongue. We're back around the second molar. Put the mouth mirror on there. The handle of your mouth mirror. Run it back. You're going to see. Wow. Isn't that convenient that nature handed us that gift? The extended tail, moving the jaw edge to edge, we're able to restrain and inhibit the tongue. We're able to stop or to reduce or eliminate snoring, reduce the AHI. Hey, dentistry is on its way. Now, here's a little more proof of what we do. And boy, do I love this. And this comes from the dental CAT scan. And I don't expect all of you to be rushing out getting these. They're very expensive, but boy, do they illustrate what we do. All right, here we are in the upper right-hand corner. All right, this is basically a cut right in the middle of the face. We're looking at the side from the laterally. Here's the front two teeth. Here's the tip of the lower chin, lower lip, upper lip. The nose is right here. Here's the nasal airway. And here's where the air comes down, goes into the lungs. Now here's the tongue. Behind the teeth, underneath the roof. Look at how big that tongue is. Well, guess what? All the people who have sleep apnea and snoring, big tongues. Look for scalloping. You learned about that in dental school. This is where you see it. And we never knew that that was the problem. Okay, but look at how it's made the airway small here. Restricted airway. Now, look at the two cervical bones here, right there. Same pattern right down here, same guy. All right. Now, we've got the full breath solution in the mouth. Here's the tail. Here's the tongue underneath. We put barium paste so we can see the tail. Now, this tail is longer. Yes, we talked about the fact that we can extend the tail. We probably extended this one probably about an inch, and some of this is the anterior tongue restraint, that portion that goes back in front of the transpalatal bar. But look what it's doing. Restraining the tongue. Up here we've got a congested airway. Here we've got a wide open airway, a super air highway, because the tongue has been held down. Wow. Good stuff. Good stuff. And we can do this over and over and over again. All right. Here's data on my latest 115 cases. Here's the age. Average age 59. Average BMI 27. Over 25, you got to start watching your weight. All right, we talked about the AHI, pre-treatment AHI. So of the 115 cases, the average AHI was 39.19. They averaged the tongue going back and blocking the airway 39 times an hour on all 115 cases. We then treated all those cases with the full breath sleep appliance. And what did we end up with? We ended up with 9.63. We reduced the AHI, number of times the tongue blocked the airway, 76.6%. I got to tell you, I am very, very proud of that figure. In dentistry, we can do so much now. We have the answers. Now, we also talked about the fact that when the airway is blocked, we got less oxygen. Well, the average level of what we call oxygen desaturation was down to 80.55%. We don't want it lowered 90. With the appliance, we bring it up to 87.18. Now, I think we can do better, and we're working on that. But we've increased it 20%. But let me tell you, this is what is huge. We're stopping those non-breathing episodes. We reduced the incidence 76%. Look, as dentists, we have the skills, the tools to alleviate some of man's greatest problems, and one of them being his lack of oxygen to his body when he sleeps at night, and the resultant poor health and health breakdown. If you're interested in doing this, you better pull up your socks, because if you get rolling, you're going to get people beating your door down because the need is out there. 90 million snorers, 60 million over 40 snoring, 27% of all couples snoring. Ask the women, they'll tell you. They're not happy with their husband snoring. But you have a chance to make changes on people that are incredible. And guess what? It's the easiest physical dentistry you will ever do. And it is the most affluent dentistry you will ever do. We got winners all over here. You're going to help mankind like their dentistry can do no bigger gift to mankind than this. Listen, we do great stuff. We take care of caries. We do endo. We do perio. We do ortho. We do orofacial pain. Tremendous, tremendous stuff. But alleviating man's breathing problems so that we can help him with the body breakdown that takes place every night. And you do this every night for a week, a month, a year, 2 years, 5 years. No wonder people have health problems. So we can alleviate those kinds of problems that he has. We can alleviate potential Alzheimer's that comes with this. So we have a chance to make health changes for man because he can't wear the CPAP and his tongue blocks the airway. Dentistry is the answer. Wow. Do you think as this increases that we're going to be looked on with more respect by the medical community? I absolutely do. I know because I'm doing it. And I know the way the MDs look at me. They know I have an answer. When that CPAP doesn't work, they're dead. They have no other answer. And the patients are left out there. They don't know what to do. And the patients are both disappointed and very bitter. And then along come the dentists, who at first they're not sure and they doubt. But as we show them with tools like the pharyngometer, that we can make a change for them. And then we use the full breath solution. We utilize the dental CAT scan. Hey, dentistry is a big winner. You're a big winner. Your family's a big winner. Can you tell? I love this. I'm enthusiastic. Now, as I told you, the answer is the full breath solution. I enjoyed doing this for you. I would love to see the entire dental industry really take this up. Look, so many in the dental industry are over 40. And boy, there is no easier physical dentistry than doing sleep. And there's nothing more lucrative. Obviously, I love this, and I hope to see you at some of my classes. I look forward to hearing from you. And until next time, because we'll follow up with more classes.